I've known people that had cancer, and the first thing I tell them is that I wish you would go and set up an appointment and see Dr. Nagourney, because I feel strongly he is the best. I owe him my life. That's the way I look at it.
Ingrid is a wonderful example of what we do, and she is a patient. I don't see very much of Ingrid because she doesn't need my care. But some years ago, Ingrid came to me with a large breast cancer, recently diagnosed. She'd seen something about my work and wanted me to take care of her.
I could never have been in better hands.
I, to some degree, strangely enough, discouraged her from undergoing the assay because I just wasn't sure the value added was present. When she went to the surgeon that I had referred her to,
he only deals with the very top-notch doctors. That's what he does.
She told the surgeon, unbeknown to me, that she insisted that the sample be submitted to me.
When they took that tissue out of me, that's when they used to test which drugs is she going to be resistant or which is going to work best for her.
When we then received the sample and processed it, at the same time as we were deciding what drugs worked for her at her request, it turned out that she had 17 positive lymph nodes, which in the breast cancer literature is tantamount to a death sentence.
When I met him, I had all my tests sent down here, and I thought, if this is not my time, then, you know, this is the one.
Confronting the reality that she was a terrible candidate for conservative therapy, I was delighted to have the laboratory data. Using it, we concocted a collection of treatments and consolidations which were quite novel at the time, including consolidation with cisplatin and gemcitabine, a regimen that I developed and published. And with that combination, this patient is now years in remission, contrary to most anyone's expectation.
We're still fighting to get this accepted. People don't actually take the time to really look at the data and look at what he's doing. He's doing good. And we're helping people, you know, one by one.
We now realize in recent years that cancer doesn't grow too much. It dies too little.
We think we don't have 5 minutes. When I went into Dr. Nagourney's office and talked to him, not only did he understand what I was talking about, he answered my concerns in such a way that made total sense.
If you want to measure what works in a patient's tissue, you cannot assess that by determining growth inhibition. You can't add a drug in and see if the cells stop dividing. That's irrelevant. What you must do in the test tube is measure whether the cells die outright. So in the laboratory, we have developed these tissue culture methods that don't measure growth and don't propagate cells and don't look at division and DNA synthesis. These tests measure death. And the terminology used today to assess this is called programmed cell death, one variant of which is called apoptosis. We have a remarkably high success rate in ovarian cancer, both in terms of finding drugs and in terms of just successfully testing tissues. For whatever reason, it's a very interesting biological attribute. Ovarian cancers will live very comfortably in test tube environments.
It's kind of fun doing the data analysis because sometimes we can mine the data and find patterns and trends that a clinician wouldn't be able to find just looking at a certain patient here and there. When we have hundreds of specimens coming through and you can really start to see trends emerge, especially for new drugs, things like that.
I believe if I hadn't met Dr. Nagourney and I was given 3 sessions of VP16, I probably would have went the normal route and went into remission for a year or so and come running back, and I'd be dead by now. I knew something was wrong initially. As we bought this boat a month before I was diagnosed, I went to raise the mainsail in Marina del Rey to go to Catalina. When I got it up, I couldn't catch my breath. The doctor that diagnosed me told me that if it were him or his father that had that diagnosis, that there was only one person in the world that he would want to see, and that man was Dr. Nagourney.
And I was very flattered because I didn't know the physician very well, and I must admit that I didn't think that I had had that impact on this physician's practice.
He's using existing technology, but he's using it in a way that's more effective.
Rather than treating patients with high doses or treating them with complex combinations, the intent from our standpoint is to utilize drugs where they work.
What they do is they say, you know, 1 in 3 people respond to this one. Well, if you do an assay, I can at least double that percentage right off the bat. How come those people at USC didn't know? How come those people at UCLA didn't know? It's not like I wasn't asking the question.
What I find very often is that physicians will poo-poo the work and make various reasons to criticize it, but if one of their family members gets cancer, or if they themselves get cancer, they call me. America is a technocracy, and so when we have a serious problem like cancer, we want novel, exploratory approaches to these diseases. And I think in a funny sort of way, we would rather have difficult, expensive things to apply to cancer that may not work than simple, inexpensive things that do work, so long as those expensive, difficult things are technologically advanced. I'm just going to be making rounds to see a patient, admit another patient. I have someone coming in from Riverside who I need to see. I'm rather sure that within a matter of a few weeks she's going to feel a lot better and that her breathing will be better. What I'm hoping most is that we're going to buy her some good quality normal life over the coming year or two or more, as much as possible. And over the next year or two, we're going to have drugs that we're looking at in the laboratory will be coming forward in more broad trials. As the therapies move down the line, we can get greater access to them. They go on to what's called compassionate use and they become more available. I must admit that I feel a sense of urgency to get her better. And I don't want to make it sound like I can cure her. I think I can make her better. I'm very hopeful I can. I don't want to, my colleagues tell me I'm too optimistic and that I don't want to overstate the situation. I give her better than 50-50 odds that I'll make her quite a bit better.
He said, you think we should know by now how to get a drug that just goes and kills what is wrong with you. He said, well, I think we should know that now too, but we don't. So he said, all I can promise you is I can give you the next best thing, which is the best we have right now.
I actually come up with some of my best ideas when I'm rowing.